go ahead. We are recording. Hooray! All right. So what we're going to talk about today is we're going to talk about an introduction to the 12-lead ECG. So now we're going to move beyond rhythm strips into 12-lead. And at the end of the class, which we're about halfway through, I believe that? You guys are halfway through this course already. By the end of the class, we will have to marry both rhythm strip analysis and 12-lead ECG analysis. And again, like I said, if you're looking for the rhythm, okay, if you're looking for the cardiac rhythm, you need to look at the rhythm strip. If you're looking for highly nuanced information, and the most important information that we typically are looking at as paramedics is we're looking at presence of ischemia, injury, or infarction. And that's primarily what we're going to focus on today. And then we're going to talk about localizing contiguous lead groups. So we know what the leads are, right? We know what the leads are. We know where to put the electrodes, right? And where those leads come from. But we need to find out, okay, what areas of the heart are these leads looking at? And what I mean by a contiguous lead group is a set of leads that looks at a specific area of the heart. That's what I mean by the term contiguous. And then finally, we're going to talk about signs of ischemia, injury, and infarction using the 12-lead ECG. However, what is the first most important step when it comes to dealing with a patient?
Assess your patient.
Yes, the clinical examination cannot be neglected. You cannot diagnose somebody as having ischemia, injury, or infarction based on the 12-lead alone, okay? You have to marry the clinical exam to the 12-lead. And that is to say, if you did a 12-lead on me as I'm standing here talking to you guys, and that 12-lead showed something that indicated ischemia, would you be well justified in treating me that way? Not if I did not have, or if I was refusing or denying complaints that suggested ischemia, injury, infarction, right? So you've got to make the diagnosis, you need to marry the 12-lead with your clinical exam. Does that kind of make sense? So don't forget that there are basically two components that get married here to make that call. Okay, so let's go ahead and talk about this 12-lead. All right. Here we go. Hey, what do you know? All right, so let's take a look at the heart real quick. And like we've talked about in other courses, there are two major coronary arteries, and I've got my little model of the heart here as well. But what are the two major coronary arteries that come off the heart?
Right and left.
The right coronary artery, that's this little guy right here, so your RCA, and your left coronary artery, your LCA, right? And then your LCA branches into two other arteries. What are they? The circumflex artery, or the circ, good, it goes along the lateral aspect of the heart, and then the LAD, or the left anterior descending artery. Now, there are other arteries, there are marginals and things like that, but we're not going to get into that level of detail today. These are the major players. And what we need to understand is that these coronary arteries perfuse specific areas of the heart. So let's start on the right side. So if you look at the right coronary artery, what structures do you think are going to be perfused by that right coronary artery? Yeah, the right atrium, right? And what important structure exists within the right atrium? The SA node, absolutely. Right? The SA node. What else? Right? You've got your right ventricle here. Okay. And what about the left ventricle? Do you think the left ventricle is going to get any perfusion from the right coronary artery? What do you think?
Sure, yeah.
Yeah, a small part of the left ventricle, and this is what we call the inferior wall of the left ventricle. So down here, Okay, the inferior part of the left ventricle is also going to get perfused by the right coronary artery. But primarily you're looking at right atrium, right ventricle, and the inferior wall of the left ventricle. So what leads, well, we'll talk about leads here in just a minute, but we'll just stay with structures. So you guys okay there with the RCA, the right coronary artery? Let's talk about the LCA. What structures do you think the left coronary artery is going to perfuse? Okay, yeah, so you've got part of the left atrium up here. Okay, what else? Yeah, actually, a majority of the left ventricle is going to be perfused by circulation from the left coronary artery. All right? And where the left coronary artery splits, so you have the left main up here, and it splits into the circumflex and the LAD. The LAD, the left anterior descending artery, is going to perfuse primarily the septal wall, okay, the septum, so those are your bundle branches in there, and the anterior part of the left ventricle, which is actually a significant chunk of tissue. Does that make sense? Now, the circumflex artery is going to wrap around the side, and it's going to not perfuse the anterior part of the left ventricle, but rather the lateral, right, the side, the lateral aspect of the left ventricle. So if you had to guess, if you occlude or you have a problem with the left coronary artery that's very high up, what area of the heart's going to take a big hit? Yeah, the left ventricle as a whole is going to take a really big hit. So pathology, specifically pathology that is more proximal, okay, in the left coronary artery, is going to be much more problematic in terms of the left ventricle taking a hit than, say, the right coronary artery. You guys okay with that? All right, so let's now talk about what leads. Look at these areas, and do you see how I have some color here, some color coordination? Yes, sir.
The circumflex artery does the posterior most of the time?
The posterior is a combination. It could be either right or left, both right dominant, left dominant. It can vary a little bit, and I won't even get into the posterior today. We're just talking about the anterior lateral part of it today, and then we'll get into posterior when we talk about more nuanced stuff. So let's go ahead and just talk about the leads. So I'm going to zoom in here. You guys see that okay? So there's my attempted drawing of the heart here. So if you imagine that I have the heart in the middle, I have Einthoven's triangle around that heart, right? Which include leads 1, 2, and 3. You guys cool with that? So if you look at lead 1, okay, lead 1 is primarily going to be looking at the lateral part of the heart. Does that make sense? Okay, the lateral aspect over here. Lead 2, however, what side of the heart is lead 2 primarily looking at? Primarily it's looking at the right side, right? And then lead 3, what do you guys think? Is actually primarily going to be looking more at the right side, because remember, how is that wave of depolarization moving through the heart? It's moving from the SA node up here down in this direction, right? Down toward the apex of the heart in the left ventricle. So if let me choose a different color. If I draw an arrow, make that a little darker for you guys. We'll make it. So if I draw an arrow in this way, the mean electrical vector of the heart is moving in that direction. So lead 3 is actually going to be looking more at the right side of the heart as that's moving from the SA node down. And then we have our augmented leads, right? Our augmented leads that are superpositions of 1, 2, and 3, and those are AVL, AVR, and AVF. Well, AVR, and you have to imagine, okay, because with the limb leads, we're looking at a coronal plane, right? A coronal slice of the body. So you kind of have to imagine that the augmented leads are kind of popping out at you a little bit, okay? So you kind of have to just use your imagination because I can't really draw that very well. So if you look at AVR, augmented vector right, okay, it pops out kind of toward the right, and it doesn't really look at a significant part of the heart. It kind of pops out toward the aorta there. And in fact, with our initial examination of the 12 lead, we don't really even use AVR to look at any specific area of the heart. However, AVL, if you had to guess, what area of the heart is AVL going to primarily be looking at? What's that? The lateral, right? The side, the left side, okay? And then AVF popping out at the front, again, what area is going to be most represented in AVF as it pops out of the front? The right side again, yeah, the right side, okay? And then your V leads, V1, 2, 3, 4, or your precordial leads are going to be looking primarily. And imagine that these are popping straight out at you because the precordial leads are on the transverse plane, right? So they're going to be popping straight out at you. And, well, primarily right or left?
Left.
Primarily left, right? Primarily left. And so what I've done here is I've color-coded these for you guys. So you see the green there? Green is all right, okay? And the 3 leads that look primarily at the right side of the heart, the right coronary artery, are 2, 3, and augmented vector front, AVF. You guys okay with that? The leads that primarily look at the anterior septal part of the heart are your first 4 precordial leads, V1 through V4. And then the leads that primarily look at the side, the left side of the heart, okay, are your lateral leads, V5 and V6, so the last 2 precordial leads, and then 1 and augmented vector left. And those are, of course, in blue. And so I've color-coded all that to the heart, okay? But to simplify this, what I want you guys to remember is this saying. I want you to remember the following saying. Move this up here. Remember, I see all leads, or ISAL. I see all leads. Write that down. This is how you want to initially approach looking at your 12 lead. I see all leads. Start at I. Okay? I is the inferior wall. When I say inferior wall, I mean the inferior wall of the left ventricle, but along with that, we're also looking at the SA node, the right atrium, the right ventricle, okay? We're looking at the right side of the heart. Does that make sense? And the 3 leads that represent that right side are 2, 3, and AVF. So I is inferior wall, right coronary artery, leads 2, 3, and augmented vector front. You guys okay with that? Then we move on to C. C is the septal wall. That's the left coronary artery, specifically the anterior descending branch, the LAD branch. And that consists of leads V1 and V2. Okay, septal wall, left coronary artery, the LAD branch leads V1 and V2. You guys okay with that? All is the anterior wall of the left ventricle. Okay, again, includes the LCA and the LAD, and those are leads V3 and V4. So V1 and V2 is septal, V3 and V4 is anterior. I see all, and then finally leads, lateral wall, the lateral part of the left ventricle, and that's the LCA, specifically the circumflex branch of that. You guys okay? So far, so good? Okay, good. And we're looking at leads V5, V6, 1, and augmented vector left, AVL. So again, to review, let me bring this back down to review. 2, 3 AVF, inferior wall, right coronary artery, right atrium, right ventricle, inferior aspect of the left ventricle, sinal atrial node. You guys cool with that? All right. V1 through V4 are your septal anterior leads. Okay, that's primarily the LAD, left anterior descending artery. You're looking at the septum, the bundle branches, and the anterior wall of the left ventricle. Lateral wall is the circumflex artery, the circumflex branch of the LCA. Okay, and that's primarily looking at the lateral aspect, the left side of the left ventricle. And that includes leads V5, V6, 1, and augmented vector left. You guys cool with that? Or so far so good? All right, cool. Now, more advanced topics, okay, such as doing modified 12 leads, V4R, 15 lead, ECGs, as well as looking at things that mimic, which there is a laundry list of things that can mimic myocardial infarction, axis deviations, things like that. We're going to cover in discussions later on in class. We're not going to talk about them today. Okay, you guys okay with that? So far so good? All right, so just remember, I see all leads. Inferior, 2, 3 AVF, septal, V1 and V2, anterior, V3 and V4, lateral, V5, V6, 1, and AVL. So far so good? Excellent. Move right on. Okay, so next what I want to do is just show you what a standard 12-lead ECG looks like. So let's zoom in here. Can you guys all see that okay in the back? So this is what a standard 12-lead ECG setup looks like. Oftentimes, near the bottom of the 12-lead, where I drew that arrow, you'll also have a rhythm strip that gets printed out. The Philips monitors that we use print a rhythm strip. The Zoll monitors that we use do not. Okay, so it can vary a little bit from monitor to monitor. But in the United States, this is the standard setup for a 12-lead. Okay, so the standard setup is on the left-hand side here. The 12-lead starts with the limb leads. Okay, so you start off with lead 1. And then underneath that, lead 2, and then underneath that, lead 3. 1, 2, and 3. So those are your limb leads. To the right of that, you have your augmented leads. AVR on top, AVL in the middle, and AVF on the bottom. So far, so good? Okay, to the right of your augmented leads, you then have all of your precordial leads, starting at V1. So V1, 2, 3, and then to the right of that, V4, V5, and V6, and you have all of your standard 12 leads. You guys cool with that? And what I've done on this 12 lead here is I've color-coded things for you guys. So again, going back to ISAL or ICL leads, let's start inferior. Okay, what leads are those? 2, 3 AVF. So that consists of these 3 leads here, and you can see that I've actually drawn them or highlighted them in green. You guys cool with that? Okay, so your inferior leads are right there, 2, 3 AVF. So now let's move on to our septal leads. Okay, V1 and V2 in this kind of orange highlight here. Anterior leads. Okay, these leads kind of get broken up. You've got V3 here in brown, and then V4 over here in brown. You guys good with that? And then finally your lateral leads, which are also broken up. Remember, V5 and V6, and your lateral leads are in blue here. And then you have to go over here to 1, and then augmented vector left. And again, AVR, we don't really use when we initially start looking at the 12 lead. So we're really only using 11. Here you go. Are you guys okay with that? So this is just an amazing thing to me, that we're actually looking at all of the major surfaces of the heart, at least the anterior part of the heart, by the 12 lead. Like, oh, the right side of the heart, okay, is on the left side of the 12 lead. Okay, so this area in green here, this is the right side of the heart. And then this area in orange and brown is looking at the left front of the heart. And then this area in blue is looking at the left side of the heart. That just is mind-blowing to me, that we're actually able to look at that way, and we're able to tell, okay, what coronary arteries are perfusing these areas. Oh, now I know, I begin to realize, oh, I can figure out, I can localize where problems are occurring in the heart based on changes that occur within the PQRST complexes of these leads. And remember when I said a contiguous lead is a group that represents a certain area of the heart? So 2, 3, and AVF are contiguous. They represent the same area. V1 through V4 are contiguous. They represent the same area. And then V5, V6, 1, and AVL are contiguous. They represent yet another area. Right, now lead 2 and V4, are they contiguous? What do you think? No, right, because they don't represent the same area of the heart. So you could not say that lead 2 and lead V4 you could not call them contiguous. You guys okay there? Now that term is going to become more important when it comes to localizing or identifying an area where I have problems. Okay, so what are we primarily trying to identify today? We're primarily trying to identify the following things. We're primarily trying to identify injury and ischemia. And then later on we'll talk about necrosis or infarcted tissue, dead tissue. So we're going to start off with injury and ischemia. You guys, so far so good? Where we're going to start, okay, is on your PQRST complex. And so what I've done is I've zoomed in on the limb leads here, V1, or 1, 2, and 3. You guys see that there on the top? All right. What we're going to do is we're going to go to the J point. Okay? The J point is where the S wave terminates. And the S wave should terminate at the baseline. So you should have your Q. So if we look at lead 1 here, I've got my QRS complex. And do you see how the S wave comes up and terminates back at the baseline here? You guys see that there? And where do I find the baseline? Well, what you want to do is you want to go right behind the T wave here, and you see the baseline here. I'm going to put a red line on there. You see that there? Did you guys see me put that line there? I'll put an arrow to it. You see that? Right there, up on top, lead 1. Right, that's the baseline. And then I'm going to draw that back here. And do you see how the S wave comes up to that baseline before going into the T wave? You guys see that okay? And do you see, could you imagine that I could have like a little J that I could draw in there, right? You imagine that there's a little J that fits in there, and that J should come up to the baseline, and then you have your T wave. Okay, so the J point should come back up to the baseline, and then you have your T wave. That area where the S wave terminates and the T wave begins, so that area between the S wave and the T wave here is known as the ST segment. Are you guys cool with that? A normal ST segment is one where you have that return to baseline. And you see I've drawn, and I'll just put an arrow here so you guys can see that. I've drawn from the baseline back through the ST segment, and what do you see? The J point touches it, right? That's normal. That's what we want to see. Now, do not use the P wave as your baseline, okay? You do not want to draw from the P wave over. You want to actually draw from behind the T wave over your baseline, okay? You guys cool with that? That's a normal ST segment, all right? Should return to the baseline at the J point, okay? If it is below the baseline, that is known as ST depression, okay? The ST segment is below the baseline. It is depressed. You guys good with that? If it is above the baseline, that is known as ST elevation. So below is depression, above is elevation. All right? So far so good? All right, well let's take a look at this here. And this is the reason I'm trying to get this recorded for you guys, because it is a lot of visual complex stuff. So let's take a look at this here. Since we know what normal looks like, let's now take a look at abnormal. All right. So here we go, V2 and V3. So right here, would you all agree that this is a P wave here? And would you all agree that this is a QRS complex? And would you all agree that this is my T wave? Okay. So go right behind the T wave here, find the baseline, right? And then draw back through. You guys see what I did there? Okay, so the J point should be like that, right? What do you notice? Yeah, if you look over here, it is depressed. It is well below that baseline. So you can clearly see that I have ST depression in this ECG. Are you guys okay with that? Okay. Let's now move over and talk about ST elevation. All right. So you guys would all agree that this is the P wave here? Okay, this is the QRS complex, and this is the T wave here. You guys all good with that? So we go back behind the T wave here, and I've actually already done it. Here's my baseline. You see I drew it there in kind of a pink color. And what do you notice about the J point? It's way above that baseline. And so that is ST elevation. You guys good with that? So we've got depression and we've got elevation. So far so good? Let me know if there's any confusion, because I don't want to lose anybody. So please just say, hey, Chris, you're losing me here. But you guys are good? Okay, I'm going to move on then. All right. So what does this mean? What does all this stuff mean? Well, ST depression is indicative of ischemia. And what is ischemia? Is it irritation or? Okay, so ischemia means a lack of perfusion, inadequate oxygen delivery to this. Does it mean that the cells are dying or being actively injured? Ischemia does not necessarily mean that they're actively being injured or they're dying or they're dead. They're at risk for dying or being injured. But just ischemia, right, does not necessarily mean there's an injury or death. You guys okay with that? It just means, perfusion is lower than it should be. Oxygenation is lower than it should be. they're ischemic. Ischemia can then evolve and become injury infarction. Okay? Classically, ST segment depression indicates ischemia. However, it may be indicative of something known as a STEMI. And what is STEMI?
ST-related MI.
Good. ST elevation myocardial infarction. Okay? ST depression may be indicative of STEMI, even though STEMI stands for ST elevation, doesn't it? In very specific instances. Okay? And in some cases, you can get ST elevation in some areas of the heart, and you'll get what's known as a reciprocal change, where you will get depression in areas opposite of where the elevation is. Okay? We're not going to identify that so much today, but we will in subsequent lectures. Okay? Hence the reason you do not make your diagnosis until you have looked at the patient clinically and you've gone through the entire 12 lead. Okay? Because it's really easy to start at 2-3 AVF, right? I. And you see lots of depression there and you go, oh, this must be some ischemia, and then you stop your interpretation, right? Because you just see that obvious depression there when there may have been elevation in other areas of the heart, and you miss that. So go through, I see all leads. Look at what's going on in all the leads, and then make your decision after you looked at the entire 12 lead. Okay? Another thing that can cause ST depression are drug and electrolyte effects, and we'll talk about those in some detail later on. Common drugs can cause ST segment changes, such as digoxin. Digoxin is a classic one that can cause this. Okay, so it does indicate ischemia, but it can also indicate many other things can cause ST depression. Does that make sense? So it's not totally sensitive for sensitive or specific for identifying ischemia. Okay. Let's move on to ST segment elevation. So if ischemia is manifested by depression, elevation indicates injury. Okay, this is the classic finding in injury. Unfortunately, there are a variety of mimics and confounding factors, such as bundle branch blocks. Bundle branch blocks can manifest as ST elevation. So they can make it very hard to identify this. Pericarditis, okay? Inflammation or infection of the pericardial sac can mimic, okay, a STEMI or ST elevation. Electrolyte anomalies, specifically potassium, okay? Potassium imbalances can really wreak havoc with the ST segment, with our T waves, with our QRS complexes. A relatively common condition known as benign early repolarization, okay? This tends to be more present in younger people. People less than 50 years old tend to have a lot of this. We'll talk about this, not today, but we'll talk about this since it can mimic a STEMI. And then paced rhythms are a big confounder as well. If you're pacing somebody or somebody has a pacemaker and that you have capture, those QRS complexes are almost always, if you have some ventricular component to the pacing, those QRS complexes are almost always going to be what? Well, what are they going to look like?
Pace rhythms?
Yeah, what do they look like?
Pacer spikes and
What does the QRS complex look like, though?
wider.
It's a wide, bizarre-looking complex, right? Because if you capture in the ventricles, right, that's a ventricular pacemaker, quote unquote, right? And you're going to get those wide, bizarre complexes. So if you have a wide QRS complex, that just really makes identifying ST segment issues very difficult. Okay? So far, so good? Okay, cool. So what is generally considered significant, right? Okay, we talked about elevation, depression, but what does it mean? These are our two standard criterions that we look at. Greater than 2 millimeters of elevation in a single lead. Okay, so signs and symptoms of an acute coronary syndrome plus ST segment elevation of greater than 2 millimeters in a single lead suggests an ST elevation myocardial infarction or a STEMI. Or greater than 1 millimeter of ST elevation in 2 or more contiguous leads. And remember, 2, 3 AVF are contiguous to the inferior wall. V1 and V4 are contiguous to the anterior septal walls. V5, V6, and V5, V6, 1, and AVL are contiguous to the lateral wall. So if I had 1 millimeter of ST segment elevation in lead 2 and 1 millimeter of ST segment elevation in lead V4, would that meet criteria for STEMI? No. But if I had a millimeter in 2, 3, and AVF, would that? Yes. If I had 2 millimeters of ST elevation, or let's say 3 millimeters of ST elevation in lead V1, would that be enough? Yes. Are you guys okay with the two major criterion there? And I'm going to put one more in. Okay? One more in. If you have signs and symptoms of an acute coronary syndrome, okay? If signs and symptoms of an acute coronary syndrome, and your patient has a left bundle branch block, even though we haven't talked about those yet, I want you to throw that in the back of your mind. And you think that that bundle branch block is a new onset. So a new onset or a presumably new onset left bundle branch block with signs and symptoms of an acute coronary syndrome, that also is indicative of a STEMI. Again, bundle branch blocks are good at obliterating ST segment elevation, okay? Unfortunately, out in the field, it's very hard to tell if something is old or new, right? We don't know unless you have an old 12 lead to look at, which we often don't out in the field. So what you have to do is you have to go, okay, this patient sitting in front of me has signs and symptoms suggesting an acute coronary syndrome, and their 12 lead shows a left bundle branch block. What are you going to have to assume in that case?
STEMI.
You're going to have to assume a STEMI, right? You're going to have to go with the worst case scenario. Because that left bundle branch block basically obliterates a proper examination of the ST segment. You guys okay with that? Whew. So far so good? All right. So what I've done is I've drawn some pictures for you guys. Okay. And these are pictures of the heart wall from the inside to the outside. So the heart is divided into 3 layers. The endocardium is the innermost layer. The myocardium is the middle layer. It's the thickest layer. It contains the heart cells, the myocytes, the contractile cells. And then the epicardium is the outermost part of the heart. And then, of course, that's surrounded by the pericardium, the pericardial sac. But the heart itself is endocardium, myocardium, and epicardium. When I have adequate perfusion, okay, of all 3 layers, I will normally get a normal-looking PQRST complex. So far, so good? All right. However, if I have ischemia or some injury to the inner part of the wall only, okay, the inner part of the wall only, this is something known as a subendocardial infarction. Okay, so it's minimal damage. The ischemia and injury has not gone through the entire thickness of the wall. And generally, the inner part of the heart is more susceptible to injury than the middle and outer part. So the injury patterns, when we see injuries occur, the injury starts from the inner part and then moves to the outer part. Does that make sense? Okay. So the inner part is less perfused, so it's tissue that is more susceptible to the effects of ischemia. Okay. And again, the classic finding there is ST depression. It's associated with ST depression. Okay. Because ST elevation is not present, okay, if there is damage to the heart that occurs, this is known as a NSTEMI, a non-ST elevation myocardial infarction. Okay, some people again call this subendocardial infarction. Okay, because it doesn't involve the entire thickness of the heart wall. You guys okay with that? Kind of makes sense there? All right. However, if you have injury that involves the entire wall of the heart, this is also known as a transmural infarction. Trans means to transit or to cover. So the entire thickness of the heart wall and the area that's damaged is involved. What typically causes a transmural infarction? Well, it's almost always caused by sudden and complete obstruction or compromise of a coronary artery. Okay, that almost always tends to be the case. However, there are some special cases. It may be due to vasospasm or vasospastic problems. Two examples that I'm going to give you today is cocaine toxicity. People take cocaine. Cocaine can cause the coronary vessels to spasm. And sometimes they can spasm so rigorously, they can constrict so much that will compromise blood flow to the heart. Does that kind of make sense? And people can have STEMIs and NSTEMIs simply due to the effects of cocaine.
Have they seen that during excited delirium?
Oh yeah.
Okay.
Yeah. Yeah. Others, yeah, in other sympathomimetic overdoses like cocaine, amphetamines. In some cases, what some of those things can do is they can work the heart. The workload on the heart is so high that it may not even be vasospasm. It may be that the workload is just so high on the heart that the heart begins to fail due to the workload. But typically with cocaine, we see vasospasm. And then there's a special disease called Prinzmetal's angina. Has anyone ever heard of that? Prinzmetal's angina. It is a type of angina that people get from spontaneous spasm of their coronary arteries. They may develop ST elevation as well. Okay. So again, here you have an example of that ST elevation. You got your P, QRS, your T, and you can clearly see nice and elevated. Okay, because the ST elevation is present, this is often known as a STEMI, an ST elevation myocardial infarction. You guys okay so far? You following okay? Tracking like a punch-out VCR? Excellent. All right, well, let's move on to infarction, to dead tissue. So when I have injury that progresses to the point of death, I have necrotic tissue, I develop something known as a pathological Q wave. Where's the Q wave at? Yeah, it's the beginning of the QRS, right? So here I have a normal P, all right, and this is a Q, this is the R, and this is the S, okay? Do you see how large the Q wave is here? You guys see that there? Okay, a Q wave that is greater than about 1/4 to 1/2 of the entire QRS length is considered pathological. Okay, pathological, absolutely pathological if it's half or more the length of the QRS. Okay, that is absolutely pathological. Okay, Q waves indicate dead tissue. Does dead tissue in the heart tend to come back? No. So, a thing that you need to know is pathological Q waves typically never resolve. Okay, they typically stay for life. So when you look at an ECG, it's going to be very hard to tell whether those Q waves are acute or they're due to an old problem. Does that make sense? Okay. ST depression and ST elevation are more acute findings though, right? Because once the heart attack, the myocardial infarction, once the blockage is opened up, perfusion is resumed to the heart, and the injury stops, the ST segments will return to normal or return to baseline, whereas whatever tissue dies as a result of that STEMI stays dead and the Q waves will remain. Does that make sense? So you can't use the Q wave to identify an acute problem from something that happened in the past. Does that make sense? You guys okay with that? But ST depression and elevation tend to be more acute findings. Okie dokie. How about you guys get out of here, take a solid 10 minutes.